This program will explain how nurses can use the Edinburgh tool to assess eating and feeding issues in persons with dementia.
Okay, so let me talk about the first patient here. It's Mrs. Sunshine. She is a 74-year-old female. She was admitted to the hospital 3 days ago. She fell at home and fractured her hip. They've done a surgical repair, and on admission, they noticed that she was dehydrated, and also by talking to the daughter, who's the primary provider for her, they live together, said that she has lost a considerable amount of weight. In fact, she states about 60 pounds in the last 2 years. And so she has a lot of concerns about her mom with eating and feeding and everything. And so she's done well here. She's done well with the surgery. She's actually now going to probably be going to a rehab facility tomorrow. So I was in there with her this morning. The students and I actually came in this morning.
Got one in my bag. Come in.
Hi there. Good morning. My name's Ruthie, and I'm going to be your nurse today. I have 2 nursing students working with me. This is Christy Quarles.
Good morning.
And
Morning.
Eli Solly.
Hey, good morning.
Hi.
How are y'all this morning?
Fine, thanks.
Good. Miss Hendricks, I saw that you were having, in the chart, I saw where you have some concerns about your mom and eating and nutrition.
Oh, yeah.
Would it be all right with you if I just kind of watch the 2 of you interact here with
Yeah.
breakfast?
Mom, don't use the knife. Use the spoon. Come on. Here you go. Put it on the spoon, Mom. Here, let go, let go. Let me just make a bite for you. There, okay. Okay, there you go. Open your mouth, put it in, like that. Open. Put the spoon in. Okay, close. Close your mouth. There you go. Good job. Okay. Your teeth are bothering you? Just chew on the other side.
That hurts.
Chew on the other side. Here, let me do another bite. Give me that. Give me the spoon. You don't need the knife. You don't need that. Put it down. Here.
We're going to let the 2 of you finish eating breakfast. We're going to go meet our other patients for the morning, and we'll be back in just a little bit. You keep doing a good job.
Thanks. You have it backwards here. Like this. There. Come on. Take a bite. Open. Oh. Come on, Mom. Open your mouth. Open. Close. Close. Close all the way. You're doing good.
I know that your mother is down in physical therapy.
Yeah.
And so I wanted to see if it'd be okay if the students and I talked to you a little bit about her feeding and just her eating patterns.
Sure.
Okay,
sure.
great. Thank you. If you guys want to have a seat. What I'd like to do, if it's okay, is since you're here and I've got this opportunity, I would like to talk to you about, it's a questionnaire that we like to give to patients or their family members to assess the feeding difficulties that they might be having. And what the point is to assess and then maybe to make a plan, an intervention, develop something that would help you for when she goes back home. It's a questionnaire. It's about 10 questions. It's a questionnaire. I'm going to go through this with you. In fact, I'm going to give you a copy of it so that you can look at it. Here it is right here. Let me just kind of explain it. Like I said, it's very common for patients with dementia to have these feeding difficulties. So what we like to do is to assess their ability to eat. Now there's 2 sections to the questionnaire. The first section discusses a level of supervision, the first 4 questions, and then the last 6 questions looks more so at the behaviors that the patient is having. So this is called the Edinburgh Feeding Evaluation in Dementia Questionnaire.
Okay.
Now what you'll do is with each one of these questions, you're going to rank either 0, 1, or 2. And 0 means never, that this behavior never occurs. 1 means sometimes, and sometimes typically means at least once a week, but not once a day.
Okay.
And then the final choice is 2, which is often, and that's usually at least once a day. And
Okay.
with each one of these questions, I can go through 0, 1, and 2 with you just to remind you exactly what they mean.
Okay, you'll have to remind me.
Absolutely. All right, let's start with question number 1. Does the patient require close supervision while feeding?
Oh, yeah.
Yes.
Oh, yeah. Every day.
So
You can't leave her alone to eat. You have to really, somebody has to be there with her.
Okay. All right. Well, that's good. We're going to give that a 2, often. The second question is, does the patient require physical help with feeding?
Oh, yeah. Oh, yeah. I mean, you saw this morning. She
I
can't
did.
even tell the difference in a knife and a fork or what to do. And yeah, you have to sort of put the spoon in her hand a lot more.
Okay. All right.
Yeah.
We're going to give that a 2, often as well. The third question is there spillage while feeding?
You know, sometimes she doesn't really shake. Her hand doesn't shake much, but sometimes she just can't figure out whether it looks like whether the food's going in or out. You know?
Right.
So there's sometimes, yeah.
All right. Well, then we're going to put a 1 for that one, which is sometimes. The fourth question is, does the patient tend to leave food on the plate at the end of the meal?
You mean like she doesn't eat all of it?
Exactly.
No, she never eats all of it.
Okay.
I mean, I can't remember the last time she ate a whole meal.
Okay. So we'll give that a 2 as well, often. Okay. Now the next 6 questions address more behaviors that are seen late in the disease. Question number 5 is, does the patient ever refuse to eat?
You mean refuse the entire meal or just a bite, won't eat a bite?
More than a bite, but would you say that she refuses to eat a good portion of the meal?
Yeah, she just keeps saying she's not hungry, and I know she must be. She says she's not hungry. She says, there's already something in my mouth. I think she means her tongue.
Okay.
But, yeah.
You would say yes. So we'll do that often as well. I saw during, while you were feeding her and she was eating this morning, she kept touching the side of her mouth. You said she has loose teeth?
Yeah, she has some teeth that have been bothering her, and we tried to get her to the dentist a few weeks ago, 2 or 3 weeks ago, I guess. And she was so combative and uncooperative, the dentist couldn't do anything with her. So we're going to try to get her back into the dentist in the next, well, as soon as she gets out of physical therapy and gets this current hurdle, you know, taken care of.
Right.
But, yeah, her teeth have been bothering her, and she talks about that a lot while she's eating.
Okay. All right. Well, good. Well, I'll make a note of that as well.
Okay.
Does the patient turn her head away while being fed?
Yeah, she gets distracted sometimes and starts looking somewhere else or doing something else. Sure. Sometimes, I guess.
Okay. All right. We'll give that a 1. Number 7, does the patient refuse to open her mouth?
No, if you sometimes you have to demonstrate. I mean, you have to sort of say open, like that way.
That's good.
But she'll, no, I don't think so. I don't think she refuses to open her mouth. She just has to be shown how.
Okay. And when I say that's good, I'm glad that you do that, because that's real important with dementia patients, is sometimes to imitate the behavior that you want. So to open the mouth or to close the mouth, that's good.
Oh, good. So I'm doing something right.
Absolutely. Absolutely. Okay, so we're going to put a 0 there then, that she does not refuse to open her mouth. Number 8, does the patient spit out her food?
No. Once it's in there, she eats it. She
Good.
just, yeah.
Okay, 2 more questions. Number 9, does the patient leave her mouth open, allowing food to drop out?
No, I don't recall that she does that. I don't think so.
Okay, that's good. Last question, does the patient refuse to swallow?
Mm-mm. You know, once she gets the food in her mouth, she seems to be okay with it. It's just the mechanics of getting it on the fork and getting the fork to her mouth and opening her mouth seems to be where all the problems are.
Okay. Okay, good. Again, we'll put a 0 there. That's great. I really appreciate you letting me ask those 10 questions. This just gives us a lot of insight into her feeding issues, and that way then we can make some recommendations to help you. And so what the plan will be now is this afternoon we're going to have a team meeting, and at the meeting will be possibly her surgeon that did her surgery. We're going to have a dentist there, so we'll talk about the teeth.
Oh, good.
We're going to have a speech pathologist, a dietitian, myself, as well as the students. And so what we're going to do is talk about this questionnaire, talk about the results. I'm going to give examples of what I witnessed this morning with the interaction. And the whole plan for this is then to come up with some interventions, to come up with some ways that will help you so that you can help to feed her and so that she can eat better.
Oh, good, good. I can use all the help I can get. You know, it's so hard, and it seems like it takes so much time every day to just get her to eat her meals, and it's just really frustrating. My sister comes in, she doesn't live here, she comes in from out of town, and, you know, Mom's lost a lot of weight in the last year, and she starts getting on me about, you know, why aren't you feeding her more? Aren't you helping her with, you know, what are you feeding her? Why is she getting... I'm like, why don't you come over here and do this every day?
Yes.
You know, so I'll take anything I can get.
Good, good. Well, that's what we're going to do. We're going to make a plan here so that we can help you.
Thanks.
And your mother.
That'll be great.
Good, good,
Okay.
good. All right, we'll be back a little bit later.
Okay, see you later.
So I wanted to meet back up with the two of you so that we could discuss today what we experienced in Miss Sunshine's room with the observation with her breakfast and with the daughter and the two of them interacting and eating breakfast, as well as the questionnaire and stuff. So I wanted to go through that with you. I saw Dr. Amela out in the hallway just a minute ago, and she asked if she could come in and kind of sit in too. As you know, she's an expert in gerontology, and that way if we have any questions, we could ask her and get some information from her as well.
Wonderful.
So based upon what you saw today in the patient's room, watching her eat, and then later with the questionnaire, is there anything that you'd like to have clarified or any comments you'd like to make?
I'd just like to ask, is it demeaning to a patient who has dementia to try to show them how to open their mouth and put the spoon in it when you know it's something that they know how to do, but perhaps maybe they've just temporarily forgotten and can't remember?
Well, that's a really good question, Eli, and I think that's one that nurses are particularly sensitive to because we want to preserve the person's integrity, even though they may not have the cognitive status that they once had. Dementia is a disease that robs persons of basically two things, their memory and their function. So by the kind of careful assessment you did already this morning, observing Miss Sunshine and then talking with the daughter, you became aware of what she is capable of, what are problem areas for her. And in terms of her memory, by doing the cueing, reminding her of what the next step is, picking up the fork and identifying the food on the fork, doing things where you actually maybe even open your mouth so that that cues her visually to open her mouth. Those all help her with the memory part of the loss. Then, when you want to assist with the functional part, you really assist her in the areas where she has some weaknesses. And for her, it seemed that the initial startup of eating was her problem. She was taking a lot of time, kind of playing with her food, but when she was directed and the utensil was actually put in her hand and she was told to bring it up to her mouth, then she could start to perform that activity. So we want to preserve and use as much of her memory and her function as we can and compensate where she needs some help. So it's really not demeaning. What we don't want to do is take away her ability to function, which would be without assessment to just assume because she has this diagnosis of dementia she can't do anything on her own. She obviously still has strengths and we want to preserve them for as long as possible, but we also don't want her to run into nutritional problems. So based on our assessment of her memory and her function, using something like the EdFed scale that you all use, you have a better idea of what's really going on and can help her.
I wanted to share with you the results of the EdFed questionnaire that we just gave to Miss Sunshine's daughter. You know, after we scored everything, she rated a 10, and the score is from 0 to 20. So she was kind of in the middle. And based upon looking at the questionnaire, the two sections we talked about, level of supervision as well as behavior, she had issues in both areas. There were weaknesses in both areas. So the point of that now is we can take this information later today to the team meeting and talk to the experts, talk to the specialists, and see what we can do. We've kind of really been able to have a very good assessment here of specifics. This morning our timing was so good because since feeding was such a big issue with this patient that we were in there during breakfast, and sometimes nurses aren't in a position to always be at the bedside when something's occurring. Right. So that was just wonderful, and that's why I stayed in there a little bit longer so that I could actually observe the interaction. And I easily could have given suggestions or intervened or done different things, but that really wasn't the point. The point was to watch them, since this is what happens. Even though it was in a different setting, normally it's in their house, it was to watch them and to see the strengths and the weaknesses so that then I could share that with the rest of the team so we could really make accurate recommendations. So that timing was good, as well as then using the questionnaire later with the daughter, who was an excellent historian, who was able to really give us a lot of good information. But the combination of the two really gives us a good assessment then now that we can share with the rest of the team. Thank you all for coming today. I appreciate you coming to this team meeting. So if we want to just start here, if anybody has suggestions, I know that you've all seen her. If you want to just start with your your assessment or your evaluation, I'm going to make notes, and then I'll just kind of summarize at the end to make sure I clearly understand what you've said, and then I'll take this back to the daughter later on today.
She does have a little bit of pocketing of food, I noticed, and seems to require a lot of verbal cues, like mother, swallow, and that sort of thing. So I was encouraging the daughter to just make sure that everything is out of her mouth before she presents another bite, so that she can have a nice pacing of the meal. That might help her. Occasionally her vocal quality was just a little bit wet sounding, and so I was talking to the daughter about giving her mother the cue to clear your throat when you hear that little sound and double swallow. So I think with these very simple little basic strategies that we can, help her out in her feeding difficulties. Of course, she always needs to sit upright when she eats as much as possible. Now that she's had her hip fracture, that may be a little bit difficult for a short time. But as much as possible, we need to make sure she's sitting up. Small bites and small sips are always good strategies, and a slow, reasonable rate, just ensuring that the mouth is actually empty before the person presents the next bolus would be a good idea for her. And I did suggest a little bit of a softer diet because of her possible dental problems, and may help her out with her chewing and the coordination of chewing and swallowing. So the daughter was very receptive to these and seemed to be appreciative and was very encouraged.
Good.
So
great. Great. Well, thank you, Becky. I appreciate that. Dr. Patel, do you want to address dental issues?
After performing the dental exam on Mrs. Sunshine, I found several teeth in the upper left to be highly mobile and non-restorable, and the recommendation there would be for extraction. There are also quite a few cavities found in the mouth, and we want to replace them with dental restorations under IV sedation, since Mrs. Sunshine gets agitated very easily. As far as after cleaning the mouth up and getting the teeth in a healthy condition, we want to maintain good oral dental care, and with her decreased dexterity, we may want to consider using an electric toothbrush, which will take care of a lot of the work for us, and perhaps some oral rinses high in fluoride to prevent further cavities from occurring. With that said, with the increased mobility, we do know that there's active periodontal disease, which can lead to discomfort, and generally speaking, patients have bad taste in their mouth, and they don't like to eat when that kind of disease persists.
Okay, Jennifer, do you want to tell us what your recommendations are?
Well, nutrition has seen her. We are in the process of performing a 3-day calorie count, and since her diet was changed to a soft diet, we have seen improvement in her oral intake. She tends to favor foods that are more of a puree or a mechanical soft consistency, and she does better with her swallow when her foods have some moisture. For example, she really enjoys the soups, the jellos. When she ate meatloaf with gravy, she did a very good job with those. I did talk with the daughter about how she's having difficulty getting her mother to eat at home, that she will sometimes eat and sometimes not. So we discussed some ways that she can increase the calories and the protein in the foods that she's already serving to her mother, so that when her mother does eat, she's getting good quality protein along with good quality calories with the nutrition that she needs.
Becky, what are some strategies to use to get our patient to eat when we try to feed her if she's refusing to accept food?
It can really happen for several different reasons. A person can refuse oftentimes because they are having a swallowing problem, and the body sort of defends itself that way, that if this isn't going well, this particular meal is not going well, then they'll just stop eating if they're sensing that they're having that sort of safety problem. So I think the caregiver needs to be always in tune with that as our first thing to think about, and we as the medical profession too. So I sort of cringe sometimes when I see caregivers sort of force feeding people who are refusing to eat, because we need to make sure that, you know, are they safely eating first of all before we sort of over encourage our patients to eat. But if that's not the case, then why else could they be refusing? So then we start thinking about maybe it is a cognitive state as a result of the dementia that they have. Maybe it's something as easily fixable as just reducing the distractions in the room. Maybe they're watching their grandbaby play over in the corner or something, and who wouldn't want to watch their grandbaby in the corner rather than eat? You know, a lot of people would rather do some other activity. So often just getting the environment very quiet will encourage the patient to eat.
Jennifer, what are easy ways she can increase her calorie or protein intake at home?
Well, that's a good question, Christy. Of course, we don't want the daughter to have to buy any medical nutritional supplements if she doesn't have to. So there are some easy things in the home that she can be using to increase the calories and protein in her mother's foods. For example, this morning she had grits and eggs. The daughter could have easily added milk to those eggs, which has a good number of calories and very good quality protein. And she could also add milk powder or just plain milk to the grits as well, instead of using water when she was making those. So there's just some very easy steps that she could do. If her mother likes cheese, she can use cheese and add that to vegetables. Or meats, she can also use margarine as a different way to increase calories. But just making sure that she gives her good quality, calorie-dense foods while she's eating will ensure that she doesn't become malnourished when she doesn't want to eat.
All right, well, these are some great recommendations, some great suggestions. I really appreciate it. So the plan now will be for me to summarize all of this with the daughter. I'm going to meet with her this afternoon, and so I'm going to go through all of these different things that you recommended, and I'll also give her some handwritten material as well. So I want to thank you again. I appreciate everything you did. I'm also going to give you this as well as this little booklet to take home. And these are just, again, some very basic, very general tips. And what you're going to want to do is then to continue to be followed by your provider, your mother's provider in the community, because this is really a baseline evaluation and assessment of where she is today.
Okay.
And unfortunately, we know that as dementia progresses, there's going to be a decline in her eating. There will be a further decline, and we hope that it will be slow, but they can give you further recommendations as this occurs. So it's important that you stay in close contact with them and for support, for any suggestions, any recommendations that they might have as well.
Okay, so to follow up, when should I make that appointment to follow up?
What I would suggest is, since she's going to leave tomorrow to go to the rehabilitation facility, when you know the discharge date from there, why don't you call your provider, your mother's provider at that point, and then just make an appointment then. And that way you can set up, because it really, especially the dental care, is going to need to be a priority, but also following up. And I'll tell you what I'm going to do too, is I'm going to make sure that your provider also gets all of this information too. The results of the questionnaire and everything, the specific recommendations that we've given, so that they'll know what we've recommended, and then they can go from there.
Okay, okay, that sounds good. All right.
Well, good. Well, thank you.
Thank you.
Okay.
Bye-bye. All right, bye-bye.
I am often surprised by the fact that people treat eating and feeding problems as almost a side issue in dementia, whereas family members actually see it as much more a grave issue. Most family members can quickly get their arms around the idea that their mother isn't eating or their family member isn't eating, and that not eating is associated with poor or declining health. Nurses may see this as only a temporary issue, especially nurses in hospital, where the patient stays for such a short time that they may ascribe the issues with eating and feeding to other situations that are going on. Perhaps they've just had surgery, or maybe they're in pain, and these could all be reasons why someone is not eating, but that we think of in the usual patient population. But dementia layers on this loss of function, so that the nurse may not realize that what is actually going on here is a complexity in neurological functioning that the person just can no longer master. They don't realize that embedded in the process of dementia, that inability to feed oneself or to eat independently without any assistance might be part of the disease itself. So therefore, the opportunity for assessment is missed, and the person may move further along the trajectory to a point where perhaps we can't stop the disease itself, but we could have maintained their integrity and their function a little bit longer if we'd been able to make some interventions along the way. Edinburgh Feeding in Dementia Scale was developed by Roger Watson, who is a nurse scientist at the University of Sheffield in England. He, like many nurses, was working in an institution and realized that the patients that he was seeing with nutritional problems had something else going on, and he wanted to be able to examine that more carefully and develop the instrument out of the result of his own clinical work. You can use the information you get from the assessment to develop interventions. Therefore, if you see someone who is, for example, turning their head away, you have to ask yourself, is this a distraction, or is there some purposeful reason why this person would be turning their head away? Is the person who's assisting them going too fast? Are they offering the food so quickly that they can't clear their mouth out? Or is it maybe that they're actually having problems swallowing? So you could address any one of those issues, distraction, pacing, or issues with swallowing itself, with different interventions. You could then go back based on your interventions and see if they were effective. Really, anyone can do the assessment. In fact, as was mentioned before, this tool can be used for observation, or you can question a caregiver about their observations of what they've seen with a particular patient. However, to interpret it really requires a registered nurse, or a healthcare provider, because you would want to have the assessment coupled with the other kinds of issues that needs to be taken into account that may be related to the disease, the environment, to issues with caregiving. These more high-level type assessments need to be done by a healthcare provider. When you do the assessment, and the frequency with which you do the assessment is best done at a time that has some relationship to your plan of care, or your potential plan of care. By that I mean, if you believe that the individual you're assessing is sundowning or having more trouble in the evening, you might want to assess a patient in the evening and then assess them at breakfast the next day, because you might want to see the difference between time of day. However, if you've put a plan of care into place, you feel like it's going rather well, you're getting that kind of feedback, then assessing the person at the same meal would probably be what you'd want to do. You'd want to do a reassessment based on the patient's acuity and where they are. In an acute care setting, it would not be unreasonable to say that you might want to, in a person who's lost a lot of weight, who's having problems with eating, who may have some other underlying problems that the speech pathologist has identified, you might want to be doing this instrument every day to see how quickly they're progressing, to see if there's any change. That may actually also be related perhaps to delirium or some other condition that may be clearing or getting worse. Other than that, probably when planned weights are done would be a good time to do it. So weekly, monthly, depending on the institution's policy. Some of the challenges related to completing the EdFed may actually be more related to cultural issues or preference issues on the part of the patient, their family, in total. By that I mean if this particular individual is a vegetarian or follows a vegetarian diet or has some sort of diet preference, and you're totally unaware of that, and they're refusing to eat pork, or they won't eat meat with dairy, or there are certain other foods that they are not eating, and you are unaware of their cultural or religious preferences. Or, for example, they would prefer pasta to rice, or they prefer potatoes. All of those kinds of long-term eating patterns do not change just because someone has dementia. In fact, they probably become more accentuated. So knowing what the person's past eating habits were, as well as what their cultural and religious preferences were, would be perhaps not a challenge, but it would be important to know, because you'd want to know why this behavior, if there's any other explanations for the behavior. One thing that is sad, and families may not realize this, is that statements are sometimes made that the person is not eating out of spite, or they're not eating because they want to get attention. And while there might be some small grain of truth in that for some persons, for the vast majority of people, the inability to eat, to comprehend this process, to appreciate the feeling of hunger, all of those issues are more related to the disease process. So therefore, if someone is not eating, it isn't out of spite or to get more attention. It's related to the disease process itself. Finally, when I think of challenges, is that the observer really needs to be attuned to what's going on. They need to watch the person carefully, because even something that I described before, turning the head away, can happen very quickly, and you can lose the opportunity to see that if, as an observer, you're distracted, perhaps you're talking to someone else in the room, you may not pick up on all the behaviors that are being displayed. Not eating can be a difficult issue for families, for caregivers, for healthcare professionals, for ancillary healthcare providers, because in almost all cultures and all societies, not to offer someone food is a taboo. So what do we do when someone gets to the point in the disease where they are cognitively not processing the ability to eat, they're unaware of their hunger urges, they may have hormonal disturbances that don't give them the cues that it's time to eat, and they are losing weight, and everyone's aware that their caloric intake isn't sufficient to support life for very much longer. Well, I can't, in a short amount of time, give you a quick answer to that. We do know from retrospective research that people with late-stage dementia do not benefit from artificial nutrition and hydration. That's never been shown prospectively, but we have some very strong retrospective studies that show that people do not gain weight. It does not prevent infections or pressure ulcers, and tube feeding, of course, can have complications of its own. However, what we really need to understand is where that person's and that family's values are placed, especially if the individual gave any sort of advance directive about what they would like to have happen if they were ever in that situation. And hopefully they shared that information with their family. If they didn't share it with their family, many times the family itself may come together and make some decision about the quality of life they want for this individual at the end of their life. Because there still can be quality of life at end of life, and whether tube feeding someone is considered quality of life or not is really for that family to decide, in the face of what we know about the current research. So we should all be encouraging everyone, including ourselves, our peers, our family members, our patients, to execute advanced directives and to make some statement about artificial nutrition and hydration or hand feeding at the end of their life.